Hello, everyone, and welcome to today's webinar, State of the Union and Beyond Detection, the Future of Cardiac CTA. My name is Sayali Tarlekar, and I'm the Global Head of Marketing at Arineta. I'm so excited to have you here this afternoon because we've had an incredible response and a fantastic attendance again this year, and we're thrilled that you've taken the time to join us. Before we start, I just have a quick update for you all. One of our speakers, Ginger B.S. Brock from MedAxiom, was unfortunately unable to join us due to a family emergency. However, the good news is that her colleague, Joel Sauer, will be stepping in to present on the same topic. Joel brings a wealth of knowledge and experience, and we're thrilled to have him with us. He'll be kicking off things with State of the Union on cardiac CT growth, use cases, economics, training, and more. Following Joel, we'll hear from Dr. Alberto Morales, and after both the presentations, we will open the floor for questions. So stay tuned for a great discussion. Now let me go ahead and introduce you to our first speaker. Joel Sauer is a nationally recognized expert in cardiovascular care transformation. Since 2010, Joel has worked with organizations across the country to drive value-based strategies, develop physician-hospital partnerships, and design effective compensation models. He brings deep expertise in leadership development, cultural integration, and service line advancement. Prior to consulting, Joel spent 14 years in executive roles, including as CEO of a large health system medical group, giving him a unique perspective on both clinical and operational sides of care. He's also the author of the annual MedAxiom Provider Compensation and Production Survey, and a trusted voice on workforce planning and emerging federal payment models. Welcome, Joel. We're so glad to have you with us. Please take it away.
Thank you, Sayali, and thank you to Arineta and to all the organizers of this webcast. It's my pleasure to be here and take you through some information regarding advanced imaging and CCTA in particular. This is meant to be a high-level State of the Union type presentation. So without further ado, I will launch into that. So apologies. Your CTA program or your advanced imaging, if you want to look more generally, is more than just the diagnostics themselves. It can actually be a strategic advantage for your cardiovascular program, driving not just volumes of studies, but also patient populations and active cardiovascular patients. It is now almost akin to the stethoscope. It is very rare for a new cardiac patient not to get some sort of imaging study, and more we're seeing that they are in the advanced imaging protocols. And it is a very cost-effective way to get a lot of information on a patient that is necessary for value-based treatment and good outcomes and cost panel. CTA and other advanced imaging modalities are growing exponentially. We've seen cardiac MR double in 5 years, and CTA has grown by more than 2.5 times. So we are seeing robust growth with nothing in the tea leaves that would suggest we're not going to continue to see that kind of increase in the future. There is a downside to this. We are replacing some of the other staple imaging technologies with these more advanced studies. If you're a patient, and for most of us, we would consider these good trades, but they do have an impact on our program, and you can see those that are in the red, so to speak, from a volume perspective. The keys to advanced imaging in terms of growth, or what's behind all that growth, big reason we're seeing expansion in advanced imaging technologies is the clinical applications or the clinical use cases. We now have CT first strategy. We even have some national payers that are saying they will pay for CT first strategies as well. we're seeing our population expand, and unfortunately, the incidence of cardiovascular disease grow with it. I'll go into more detail on that with a little bit of science later on. Programs are keying on it. We have many programs that are offering either free or reduced calcium scores and other lures to get patients into our programs. And then we have physicians who are being specifically trained in cardiac advanced imaging, and they are driving program growth and pushing their CV programs to be bigger adapters and build that into their care pathways and protocols. So between 2019 and 23, a 5-year period, and these are based now on claims data, whereas the previous data I showed you were MedAxiom membership data. Cardiac CT volumes more than doubled in that 5-year period based on those claims data. 2023 is the most recent year we can get because claims data out of Medicare and other sources tends to lag. But we were closing in on 1 million studies a year in 2023. And based on the growth trajectory that we have been showing you, will be over 1 million the next time data are released. And in many of those cases, more than half, the physician who was interpreting that was not a radiologist. And we know from those data that most of that half was cardiology. And then a lot of these studies are being done outside of the hospital place of service, the hospital care setting. They are done in independent diagnostic testing facilities, or they are even being done in physician offices. This is a relatively busy slide, but the take home from it is MedAxiom did a survey of its members. We actually called programs on the phone and talked to them with questions. And what we found is that they continue to be bullish on their advanced imaging programs and CCTA in particular, expecting significant growth over the coming 5 years. So the trend that we showed you earlier is looking like it will continue. We're also seeing expansion of the clinical use cases, which only strengthens that bullish consideration. As I mentioned earlier, both the population in the US is expanding, but unfortunately, so are the risk factors most commonly tied to cardiovascular disease. And therefore, even looking out on the long-term horizon, the study that is referenced here that was run in the Journal of the American College of Cardiology was looking out 35 years and projecting significant increases, unfortunately, in the prevalence of coronary artery disease and therefore the corresponding volumes of imaging and procedures that will be done. So if we are feeling stressed in our programs from an access perspective today, it is not likely to subside anytime soon. The other thing we're noticing in MedAxiom data is the number of fellows coming out of training are not keeping up with this demand curve. So we are having to lean on new ways of seeing patients, and advanced imaging is a part of that strategy. We have now, I mentioned the workforce expansion. We now have 60 advanced CV imaging fellowships in the United States. They graduate anywhere from 1 to 3 fellows per year. So we're adding about 60 to 120, depending on those programs and their size, new physicians who are trained in advanced imaging and are looking to do those types of services in the programs that they join. Most are eligible for certification in other imaging technologies, and we're seeing an expansion in PET-CT, particularly around the cardiac space, as well. So key considerations if you're looking to add cardiac CT in your program. First of all, you want to make sure that you have your cardiology program aligned around it. They would own because they will drive your patient volumes regardless of who owns the imaging technology itself. When it comes to program ownership, not that these are the only three options that are out there, but they are the ones we see 90+% of the time. It's either owned by cardiology, it's owned by radiology, or in some instances, they share it. And when we talk about ownership, we mean who gets to make the decisions around the equipment choices, who has the operations in their budget. And we see it pretty evenly split between cardiology and radiology. There are often contracts that need to be considered. Some of these are legacy going back decades, but those are the type of considerations you need to check into when you develop a program. But as I started to say, cardiology will be the driver of volumes for these modalities. And so therefore, we want to make sure we're doing the legwork up front to have imaging built into our clinical pathways and into our referral patterns. We need to make sure we have the appropriate amount of capacity in our scanners and in our imaging modalities to handle the volumes we're projecting. And then looking out into the future, how do we make decisions when technology ages out or we have new technologies that come to the fore and we need to consider adopting them? So what is that capital process for making decisions? Defining value is becoming more and more important. We have all expected the value transition to happen faster than it has, but it is still on the horizon. It has not disappeared entirely. And we know access is a big bottleneck for most cardiac programs, but it's also a big definer of value from a patient perspective. So we want to know what we are expecting and then be able to build our capacity to handle that. These studies, these tests are not generously reimbursed, and therefore we have to be very cognizant of collecting all the revenue that is owed to us, but then also keeping our expenses at a place where we can turn a margin on them. And where are we going to have our bottlenecks if imaging volumes double again in the next 5 years? Is it on the scanner? Is it with our staff? Is it within our locations? Is it with our interpretations? We need to be able to anticipate that and head it off at the pass. As I mentioned earlier, we are seeing programs use imaging as a strategic advantage. They are saying, hey, look, we're leaning heavier on non-invasive technologies rather than invasive, and that's a big deal to the patients. And then value-based care. Advanced imaging tends to be a very low-cost alternative to invasive studies and yields a lot of information that's valuable for ongoing care for the patient. I mentioned the reimbursement. Here you can see those. You will notice the OPPS is the hospital-based services, and they have anywhere from a 22 to 70% increase in reimbursement over the off-campus hospital place of service 19 or place of service 22. Those are the office and IDTF. However, none of them are overly generous, so we have to be very, very strict with our expenses, and we have to make sure that our throughput, our efficiency, our utilization remains high because obviously these are expensive technologies as well. From a survey we did, we found that the decision process for new capital, particularly things that are on the order of $1 million plus, has to go through multiple levels. It always starts from the clinicians, from the physicians, but it inevitably has to go through our executive leadership team, particularly in a hospital or health system. And that we know is competition for those capital dollars. So making the case or telling the story behind why we need these technologies, and then that return on investment or ROI story is critical as well. So with that, I'm going to turn it back over to Sayali and go off camera here.
Thank you so much, Joel. That was a fantastic overview and such a valuable insight into where cardiac CT is headed today. Now I am excited to introduce you to our next speaker, Dr. Alberto Morales. He will be presenting the topic Beyond Detection, CCTA, and the Future of CAD Treatment and Monitoring. Dr. Alberto Morales is a highly respected multi-board certified cardiologist based in South Tampa, specializing in advanced cardiac imaging and preventive cardiology. He serves as the director of the Advanced Cardiac Imaging Fellowship program at South Tampa Cardiology, overseeing training across 7 cardiology programs in the HCA West Florida division. Dr. Morales is a recognized leader in lipidology and cardiovascular disease prevention, known for pioneering clinical strategies to reverse atherosclerosis and lower Lp(a). As a key opinion leader for Novartis, he has been instrumental in advancing lipid-lowering therapies and driving innovation in atherosclerotic cardiovascular disease risk reduction. Dr. Morales, welcome. Please go ahead and begin your talk.
Thank you, Sayali. Good afternoon, everyone. Thank you, Arineta and FSCCT, for sponsoring this event and inviting me to speak. My name is Alberto Morales. Over the next 20 to 25 minutes, I'd like to share how implementing an advanced cardiac CT scanner has transformed my clinical practice. I'll be highlighting certain key observations in the realm of using this CT technology and the improvement in detection, earlier detection, as well as a personalized treatment or algorithm that will shape the future of CAD and preventative cardiology as a whole, and how we're already taking a lead on this. So here are my disclosures. So my practice is predominantly a focused outpatient preventative cardiology practice. I stopped going to the hospital several years ago. We also serve as an advanced multimodality imaging center for Tampa Bay area. We perform well over 4,000 or 5,000 CT scans a year. And we installed the Arineta Spotlight in the end of December of 2022. We started scanning patients in January of 23, excuse me. So you can see the Spotlight, a very small footprint, extremely fast rotation speed, 560 slice, very, very high tech CT scanner. Here it is in our office. And as you can see here, it's a very small footprint. You can fit it almost in any medical office. And it's one of the reasons we decided to go with the Arineta Spotlight. In addition to its enhanced capabilities, the price point, there's no better scanner out there for the small footprint and the information, the information obtained. Here's the control room. And right off the bat, once we started implementing it, we saw a significant difference compared to, I used to read for a hospital. I still read for the hospital. It was a 64 slice. And on and as you can see, the orange slide, we are instantaneously saw a significant reduction of contrast by almost 40 to 50%. The radiation dose, we were averaging somewhere between 8 to 40 millisieverts of radiation on a 64 slice. Now we're able to do a calcium score and a CT angiogram for under 3.5 millisieverts. So a significant 80% reduction. And then the accuracy of interpretability went up to almost 99%. So our previous pathway, you're limited in your tools, and when you're using 64 slice CT, you're kind of focused on symptomatic. I think this is the general consensus for general cardiology. We wait for patients to have symptoms. We perform 8 tests, CT first strategy, 64 slice. You get a stenosis. If it's severe, you send them for cath. If it's sort of this intermediate lesion, you do additional tests, whether it's stress testing or CT-FFR, and most of these patients end up going for cath, and on goes this vicious cycle of waiting for patients to be symptomatic. Right off the bat, we realize, with this significant reduction in radiation, high quality image, reduction in contrast, that we could shift our practice from screenings, from looking at symptomatic patients to screening asymptomatic patients. And that's exactly what we did. We started off by screening 50-year-olds. You can also use this technology, since it's allows you to screen patients and have very low radiation and contrast. You could perform potentially serial surveillance monitoring on patients. And so now, fast forward to today, we have scanned well over 8,000 patients, most of which are asymptomatic. We have this registry called the Tampa Insight Registry, where we're collecting multiple data set points, multiple metrics, demographics, exam, contrast, radiation, the image. We use Clearly AI for a lot of our plaque volume morphology data. All patients get a questionnaire. Therapies are monitored, what types of therapies before and after treatments. We monitor their labs. We have risk calculators. So a significant data set, a registry of information. We're waiting to get 10,000 patients, and the data is currently ongoing as we speak. So why CAD screening? I think it's self-intuitively that the most common cause of death in America is heart disease. However, if you look at ICD-10 codes, the CAD is nowhere near a common diagnosis. We have hypertension as the premier most common diagnosis in America, and that's self-intuitive. It's easy to just put a cuff on someone. It's easy to measure your cholesterol by drawing labs, but CAD is a diagnosis until you have symptoms and you undergo a cath or undergo a procedure such as a stent or bypass. It's rarely diagnosed. So if you're a 40-year-old, what is the most common cause of death? And this is a question I get answered oftentimes when they come see me. And for a 40-year-old, the number one cause of death is still a heart attack. And so if you look at a 40-year-old, CAD is nowhere near as far as a diagnosis. And it's self-intuitive. We're not looking for the disease. We're using surrogate markers, hypertension, hyperlipidemia, diabetes. So again, you can't treat what you can't see. So let's look at prevalence. So if you look at the most common 2 sites that we use, the American Heart Association and the CDC, if you look at the CDC, the AHA, for a 40-year-old, if you're a male, 7.5%, if you're a female, 6.5%. This is a significantly low likelihood that you have CAD at this, just based on this results. And again, if you're CDC, again, it's well under 8% for a 40-year-old. So how is that paradox? How is it that the most common cause of death for a 40-year-old is heart disease, and yet it's the least diagnosed and the least prevalent according to the AHA and CDC? How does this make sense? So let's dive in. So I know this is a busy slide, but if you look here, you got well over 40,000 by Virani. This is the most recent prevalent study. The AHA, 50,000, the CDC, 31,000. Again, over 30,000 patients. So you got to believe this data, right? And so they're looking at statistics for 40-year-old is well under 7.1%, 7%. So as you start looking at how is this information obtained, and it's surveys. So if you look at it, these are, you're looking at diagnosis codes. Again, ICD-10 codes are very low likelihood that you're going to find it. And then surveys. So if you ask a 40-year-old, do you have heart disease? And no test has ever been performed on them, of course they're going to say no. So interestingly enough, in 2019, the AHA used a different method. In addition to doing these named surveys and Medicare claims, They also look at calcium scores in the MESA and Framingham registry. And would you know it, for a 40-year-old, the percentage went up to 40%. So so let's look at that. So in 2019, when you use calcium scoring, which is able to measure calcified plaque, if you were 40 years old, the likelihood that you had CAD was 40%, and then it dropped right back down to less than 7% when you go back to surveys. So every single patient that we scan, we ask them a question, we give them a questionnaire, and it's almost universal. Almost every patient, when you ask them, do you have heart disease? Do you have CAD? Do you have, they all say no. And so I just, you know, we have well over 8,000 patients. We're still collecting the data, but we looked at 1,000 patients that had confirmed CAD, and then we looked at their surveys, and well over 90% said that they had no CAD. What this means is that this is a very, you know, until you look, you're not going to do it. You're not going to be able to answer this question. If someone's never had a blood pressure cuff checked and you ask them if they have hypertension, of course they're going to say they don't have hypertension. So we looked at calcium scoring, just a small sample from October to February of 2025. And well over 1,000 patients, and well over 416 had CAD. So this is the non-calcified plaque. This is the soft fibrous plaque that you don't see on calcium scoring. So this is 4 out of every 10 patients with a 0 calcium score have CAD. So if you add that and you adjust for the AHA 2019 calcium-based survey, this is probably exactly what we're seeing. I'm seeing on average somewhere between 60 to 70% of patients between the age of 40 and 50 have CAD. And this fits with the model that the #1 cause of death for a 40-year-old is CAD and heart attacks. So you may ask, well, this is subclinical CAD, it's not important. But it is important, because up to 70% of heart attacks occur in these subclinical non-obstructive lesions. These are lesions that are missed by ordinary stress testing that often become unstable and are prone to rupture. Multiple studies have confirmed this, including Confirm and Scott Hart. And so why not just wait for symptoms? Well, the problem with waiting for symptoms is that roughly half of people who have died of a heart attack, that was their very first symptom of heart disease. They had no prior history, and the very first symptom is usually either a heart attack or sudden cardiac death as a result of heart disease. So waiting is still too late in the course. That's almost like waiting for someone who has lung cancer to develop hemoptysis and then looking for lung cancer after the fact. This is an advanced, so symptoms is an advanced feature of a disease pattern. And in order to beat this disease, we have to screen earlier. So atherosclerosis is the disease, not ischemia, and certainly not these surrogate markers. So that's the key. Another thing that we have found is that, and when we started screening 50-year-olds, we started noticing that roughly a good portion, 30 to 40%, had advanced disease. And obviously the data is ongoing collecting. We're collecting all our information. But as these 50-year-olds started coming in, we started noticing a lot of 70, 80% blockages in these asymptomatic people. And since then, we've expanded our screening for 40 and even 30-year-olds. So it is not an unknown thing. As a matter of fact, they've looked at this as Confirmed, Scott Hart, and autopsy studies, that a good portion of patients with advanced disease, severe symptom, are asymptomatic. And oftentimes these patients are excluded from surveys, and they remain very high risk for sudden cardiac arrest and symptoms. So CT, FFR, what if we start screening and we start finding all these diseases at very early stages, such as what I started finding out at the conclusion of these patients coming in with disease after disease and stenosis after stenosis. Again, totally asymptomatic. You could use FFR to help kind of guide which patients go into which bucket. But we started noticing that a lot of asymptomatic patients with obstructive disease had positive FFRs. So again, that may lead to a increased referral in the cath lab. Is there, so I postulated the question, is there a better pathway for these patients? So we use, clearly, there's obviously other companies, Elucid, HeartFlow, that do a lot of plaque morphology, FFR, but we're using, so I want to share some cases to kind of show what we're doing and potentially allow you to see that there might be a better pathway for some of these patients. So as these patients are coming in with advanced disease, we had to make a decision. Do we send these patients for cath, but they're asymptomatic, but they're positive FFR? And this patient happened to come back and see me. So we had scanned this patient in 2016. She was not our patient. She was a referring doctor's cardiologist practice, and we called a high-grade proximal LAD lesion, as you can see right here. She had a 0 calcium score with a high-grade lesion. I called it 70%. Clearly, AI called it 54%. And as you can see here, a lot of this is soft, fibrous plaque. There's no red component, so no significant low-density component in there. She had tried multiple statins. I think she was on high-intensity statin. They had offered her a cath. She was minimally to not really significantly symptomatic, so she had refused the cath. And I think she was placed on various statins. Finally was on Livalo. She was also on PSK9 on and off at the time. These were her last labs since her follow-up scan. So she came back from 2016 to 2023 to get her follow-up scan, and this is her follow-up scan, just on medical therapy with no stents. And as you can see here, there's a significant reduction. Clearly called it 33%. We called this less than 25%. It's very difficult to see. I'll put these images side by side so you can see. But just to highlight here, in 2016, we did not use, clearly, I don't even believe the technology was out, but we did run her old scan through clearly under ischemic product that showed that she did indeed have ischemia down that LAD and diagonal system. On the follow-up scan where the plaque regressed, you can see that the ischemia had resolved. We also did send this to HeartFlow for comparison. As you can see here, her initial lesion of about 70% didn't meet a stepwise significant reduction, but distally you can see significant apical ischemia. And then on her follow-up scan, you can see that her FFR had significantly improved with no further ischemia distally. So I'm going to put these images side by side so you can see a case of plaque regression from 2016 to 2023. So seeing this case allowed me to say, you know what, we can treat most of these patients in this manner, and that's what we have done. So clearly it has a really nice product. It's called Compare, where you can actually compare previous plaque morphology. As you can see here, she had a plaque volume of 141 cubic millimeters of plaque. We eliminated almost 85. She had a significant reduction down to 56. A lot of her non-calcified plaque had resolved. She had shifted to calcified component. She did have a little bit of low density plaque at 2.6. This is the alarming, the high risk plaque, and it was almost completely gone. So a very nice case of plaque regression in the sense of plaque volume reduction, as well as percent stenosis reduction, and as well as ischemia resolution. So here's another case, a gentleman that was 57. He had some mild shortness of breath, was referred to us with pre-diabetic symptoms and some vague symptoms, had a nuclear stress test that was normal, had some other testing, pulmonology, and they referred him to me. We did a CCTA, and obviously you can see he had a high-grade lesion at the prox portion of the LAD. And at this point, I was very concerned for him. I wanted to send him for a cath. However, his platelets were very low. His white count was low. And we ended up eventually diagnosing him with myelodysplastic syndrome through hematology. So I'm glad we didn't send him for cath. We opted to treat him aggressively. And you can see here, clearly called it 66%. And you can see a good bit of this was non-calcified plaque with some blue calcific components. So when we saw him, he was already on Crestor 40. He weighed 230 pounds. He was And his LDL was 32. He did not have an LP(a) back. His A1C was 5.3. So there wasn't really a whole lot we could add. We tried to get him on Repatha. We couldn't. And we ended up just putting him on Ozempic as a result of his elevated BMI and pre-metabolic syndrome. So he ended up losing almost 22 pounds. And 1 year later, we performed a follow-up CT scan, and you could see a significant improvement in that Proxel-AD. You could see the plaque volume has shrunk. A lot of the plaque has shifted from a lot of non-calcified to more calcific component. The percent stenosis has gone from 70% down to less than 50%. As you can see here on his prior scan at 66, he was ischemic in all beds, diagonal, diag 2. On his follow-up scan, the ischemia had improved, but not completely gone away. And this is by AI ischemia. As you can see here, his 2023 scan up top, 2024 scan at the bottom, you can see a lot of this soft fibrous plaque had shifted and shrunk and shifted to calcific component. And then when you look at the compare, where you can take volume data sets, you can see that his plaque volume had decreased by 11.4 cubic millimeters. His non-calcified plaque volume had reduced significantly, and his calcific plaque volume increased. Again, these are all changes consistent with stabilization and plaque regression, as you can see, in the form of plaque volume regression and as well as percent stenosis. Case 3, and I'll end with this case, is a gentleman who was adopted, 57, very active with no symptoms, did not know his family history, and he had a CCTA, he had a 0 calcium score, and you can see a very high-grade lesion in the Proxel-AD. We called it 70, greater than 70%, clearly called it 70%. And you can see here, most of this was soft and fibrous plaque. If you look closely, you can see some red plaque right in there, some red density. That's consistent with a vulnerable, low-density, high-risk plaque feature. He was not on any preventative therapy. When we got to him, his LDL was 108. He was always told that's kind of borderline, just adjust your diet. But by screening and diagnosing him, if we had failed and stopped with a calcium score, we would have missed this. But by doing the CT angiogram, we were able to find that he had a significant plaque and percent stenosis, and not only that, a high-risk plaque. So we started him on Crestor. We increased him up to 20. We also put him on Repatha, PCSK9. And we also, because of this high-risk plaque, we also put him on dual antiplatelet therapy. And as you can see, we were able to reduce his LDL from 108 down to -10. His LP(a) did come back finally after treatment, and it was at 50. We assume it was a little bit higher, probably because he was on PCSK9. We didn't wait 12 months. We scanned him in 6 months. And as you can see, there's already a significant improvement in his plaque volume, significant reduction from 70% down to 50%. His initial scan, you can see here, a high-grade Proxel-AD with significant ischemia. And then on the follow-up scan, 50% with no ischemia. So you can see we resolved his ischemia as well. And we're going to put these images side by side. As you can see here, significant plaque in 2024. And then 6 months later, a significant reduction in improvement and decrease. As we look at the compare, his volume continued to go up a little bit over a 6-month period. So not quite right there, but his low density non-calcified component went from 3.2 down to 0. So we were able to eliminate that, and obviously a 70 to 50% reduction. So what I would implore you is that there is possibly a better option for these patients, especially when they are asymptomatic. So a possible shift as we start, as we evolve into screening and we start finding significant disease in patients, where we may arbitrarily use a model like CT-FFR to make an easy decision as to who goes to cath or not. we might want to look at an option for these asymptomatic to minimally asymptomatic patients in an aggressive treat, and see again surveillance approach to monitor these patients, to have sort of a personalized approach to each patient. This would lead to a significant, obviously, cost reduction and a significant reduction in interventions. So I want to wrap up with just kind of some key points that I've overlaid. Is obviously we have a significant problem in treating CAD as a result of significant underreporting, underdiagnosing. We don't really understand the true prevalence of CAD. We have large registries, large studies, that are hopefully going to highlight this information very soon. Calcium score that's 0 does not exclude CAD. I'm currently seeing roughly 40% of patients who have a 0 calcium score have CAD. There are lots of patients who have advanced CAD who are asymptomatic, who may fall into this sort of Pandora's box if we find we're going to start sending a lot of these patients, where optimally we may be able to aggressively treat and stabilize their disease. And then obviously plaque regression and stabilization is a real phenomenon. And with that, I'd like to close and turn it over back to Sayali. Stop sharing the screen. Okay.
Thank you so much, Dr. Morales. That was very insightful and engaging presentation. Now we would like to open the floor for questions, and we'll try to get to as many as possible in the next few minutes. Please make sure you're sending questions in the Q&A chat and not the other chat. Somebody did ask me if these slides will be available. Yes, you should see them on Arineta's website under the webinar section. And I have a question here that I would like to ask. Can general CT technologists be cross-trained for cardiac imaging, or should we plan to recruit technologists with dedicated cardiac experience?
Do you want to take that, Joel? Do you want me to take that?
Why don't you start, and
Okay.
then I'll
All
add
right.
from a organizational standpoint, not a clinical.
Sounds good. Sounds good. So what I would say is that from a CT tech perspective, if the tech is very dedicated to imaging and they're not a dedicated CT tech for cardiac imaging, and they could perform it, I would avoid, however, with these advanced protocols like bypass studies and certain, I think in that instance, it might be best to have a dedicated CT scanner tech, assisting with these procedures. However, it's not uncommon for a hospital-based system to have a CT scanner that's employed for multiple different uses. And if you have a tech that's very dedicated to cardiology and learning the expertise involved in educating patients and the protocols, I don't see an issue with that.
Yeah, and we certainly see a lot of cross-trained techs in the real world. One thing to note is state licensure does come into play, so you'd want to check your state rules to make sure that that there's nothing there that would trip you up from a cross-training. And then we would just strongly encourage you to do competency checks on a regular basis.
Right. We have a couple more questions here. Let me read them to you. Is getting repeat scanning for monitoring easily covered by insurance? How often can you continue monitoring, and what are the risks of ongoing radiation exposure, especially on young patients?
Great question. Great question. So, right now mammography is, somewhere between 0.8 to 1 millisievert, as far as radiation. And so those are all great questions that a personalized approach for each patient might be different. And this is by this serial monitoring, it's not a permanent decision. It's a doctor-patient decision. A lot of this is not covered by insurance. A lot of this is done through cash pay options. However, there are some large randomized trials ongoing, such as the Transform and several registries, including my registry, that's going to hopefully answer this question and hopefully change this coverage issue. However, for right now, it is not a routine coverage issue. Radiation is a real thing, and I would not be performing surveillance imaging or screening if I did not have a sophisticated advanced imaging scanner that allowed me to significantly reduce the radiation. So for instance, this gentleman that I scanned in 6 months, I did not repeat a calcium score on him. He had a 0 calcium score previous to that. And we were able to do his second follow-up scan for 1.5 millisieverts of radiation. His initial scan was, I believe, 3.4 millisieverts of radiation. So if you add that up, that's roughly under 5 millisieverts of radiation. At the hospital where I read at 64 slice CT, where it was not uncommon to give someone 18 to 25 millisieverts of radiation. So again, it depends on the technology that you have. It depends on the clinical scenario and doctor-patient interaction.
Right. Thank you. The next question is, do you think 10.000 CCTA are possible with 230 working days per year? That is with 5 days per week and 7 hours a day office.
I presume what they're talking about is 10,000 scans a year, which would be about a 45-minute template if I am doing math well in my head, which is very dangerous. We have seen that. As Dr. Morales says, it really depends on the scanner you have, the throughput, your tech, how quickly you're bringing patients back from the waiting room and getting them prepped and getting them ready and then getting them out and turned over for the next one. But we have seen programs do it. I would say they are the overachievers. They're not the rule, but it depends. And Dr. Morales, you might have something to add there.
Well, I would say right now we're averaging anywhere from 15 to 20 CTs a day, and I'm the only reader right now. So and we're working on some days Monday through Saturday. So that's a lot of volume. That's about 120 scans a week. And we close shop around 3 p.m. And so you would need a lot of readers. You would need a team that would have to work after hours. And so it's, scanning 4,000 is a lot in 1 year. Scanning 10,000 is a significant bit. So it depends on the system. It depends on the office, how many readers, your staff, the technicians, availability, and obviously the sophistication in the process, right? You have to have a good pre-medication protocol system in place so that patients come already prepared, so that it's a simple put in the IV, pop in the nitroglycerin, you have a fast scanner, and you're in and out. So a lot of things have to be running in perfect unison in order for that to happen. But yes, definitely can happen.
Thank you, Dr. Morales. There's one more question we have, and it says there are 2 parts. How accurate are the plaque thresholds on CT imaging, that is separating calcified from non-calcified low-density plaques? And question 2, do you see any benefits for photon counting CT in improving the resolution of plaque detection?
As far as how accurate it is, I have had the luxury of using 2 AI companies and kind of comparing them. And I've seen very similar information from both plaque volume, percent atheroma, non-calcified calcific components. Some of these AI relies still on some technicians to trace the wall correctly. And so in some instances, plaques could be missed depending on how the walls were lined up. But I would say it's very accurate. And what the second question, which is photon scanning, which uses a different technology to acquire more photons and allow even more precise imaging and sharper imaging, yes, will definitely enhance the quality of the image. It definitely enhance plaque volume, plaque percent, and they've even done some studies comparing traditional CT to photon scanning, and shown that the quality of the image has a big impact on the determination of plaque volume and characteristics. And I would say that's true for just me reading a scan, right? If the quality is not good, I might overcall or undercall. And so the AI, I would say, has a similar problem if the quality is not as good. And these photon scanners can definitely precisely define sharp characteristics of the wall, et cetera. However, they're extremely costly right now. And so only major centers are having those.
Thank you. Next one is, what is typical radiation dose for CCTA patient using the Arineta scanner?
So I can answer that because on average, a calcium score, we could do between 0.4 to 0.8 millisieverts. And then the CT angiogram part, if we take out the calcium score, we can do for between 1.5 to 2.5 millisieverts. And again, this is dependent on average body size. As you start, increase BMI, that the radiation is going to go up if you are scanning higher. But a typical average male, female, we average under 3 millisieverts routinely and not uncommonly.
Are you using the scanner for structural planning procedure, TAVR, LAA?
Yes, we can. We use it. I scan bypass cases. We scan TAVRs, mitral valve, you name it. We've done it for everything. So it also performs peripheral vascular runoffs. We read carotids, you name it, anything vascular, the scanner is extremely well equipped for it.
Great questions, everyone. We have time for maybe one question. And if we didn't get your question today, feel free to email us at marketing@arineta.com and we'll reach out to you with some answers. One last question. What clinical training and credentialing are necessary for cardiologists to confidently interpret CCT and integrate into patient care?
So I guess the question comes down to what would you to be level 2 trained, you need some hands-on experience, some training, several, at least 20 plus hours, and have to have examined over 150 plus cases under a level 3 reader so he could sign off on that. Some people can do a week course and get level 2 training. What I would say is that may not be quite sufficient to feel very comfortable reading CT. And so level 3 reading is obviously, in my opinion, the preferred method to take ownership. I think there's level 2 training where you could sort of decide which types of patients you feel comfortable reading. And I'll be honest, the AI has now enhanced that capability. If you have a company such as HeartFlow, Clearly, or Lucid, where now you can have sort of this backup. We kind of use it as a backup level 3 reader, right? The AI assists me in reviewing what we've read. So we hold an advanced imaging fellowship program. We also train fellows from other hospitals. And so in our program, we have a fellow that reads it. The AI reads it, the advanced imaging fellow reads it, and then finally I read it and I review everything, right? So we have multiple layers before the interpretation is released. And so for level 3, obviously it's a full year of training, well over 300 plus cases. And so, you've standards by the FSCCT, and so forth. So I think you can do it at level 2. I think if you have AI, if you have some assistance, potentially radiology overread, I think you can do it with level 2.
Great. Thank you, Dr. Morales. Thank you, Joel. And I want to say thank you to our audience for joining us today. We truly appreciate your time and engagement. And as a quick reminder, Team Arineta will be in Montreal this July for the FSCCT meeting, and we'd love to see you there. We also have a breakfast symposium where we have some exciting speakers lined up for you. So make sure You come say hello to us. Thanks again, and we look forward to seeing you in Montreal.